right, type 1, and talked about how it's inherited and how it can happen generally or, right, or local. It's going around this morning. I was late. So same thing as we always do as far as an adaptive immune response which produces antibodies. It's going to start out with our system recognizing that foreign substance. The unfortunate thing with type 1 IgE mediated immediate type reactions is that the B cells, unfortunately, are programmed by the T cell to switch to which class of antibody? IgE, right? They switch to IgE, right? Remember, Erica hates IgE, right? Because she has too much of it. So that's why I sound the way I do right now, because it's good old allergy season. So my problem is that my body has made IgEs to things like ragweed, right? And other grasses out there. So what happens is I have IgE in my body. It binds to the mast cells and basophils. Then the second time I'm exposed, right, those allergens bind to the antibodies that are already on the surface of the mast cells and the basophils. So literally immediately they degranulate and they release things like histamine, right? And histamine is a vasodilator, right? It causes the blood vessels to become permeable and you get the inflammation in that area. So for me, when I inhale the pollen, this happens in my nose, right? In my nasal passages, and I can't breathe through my nose. Heparin? Heparin, yeah. No, histamine is the main one that I want you guys to be aware of. It's the one most people are aware of, right? So people like myself take antihistamines, right? But the key here, though, is you really got to take them before you're going to be exposed. That's going to give you the best protection. Because you want that already in your system so that when this happens, that histamine doesn't have anything to bind to. Because what antihistamines do is they compete with the receptors for histamine. So they bind to the receptors that histamine would bind to, so that when the histamine is released, it can't bind to those receptors because it's already taken up. Make sense? Right? So, but first of all, that very first exposure, right, you've got to get the production of the IgEs. Just send it back around just in case. Did everybody sign the pad today? We're good? Okay, all right. Then I'll just take it. Thank you so much. So you're gonna produce these antibodies. The problem is remember, whenever we produce antibodies, right, these plasma cells are one thing that's made, but what else is made when we proliferate? Memory cells, right? So my body remembers this and just keeps doing it over and over and over again, right? And so for some, it gets even more aggressive, right? Because, again, they think it's something bad. Your body thinks it's something bad, right? So you've got these memory cells already there. They get activated, right? They turn into plasma cells. They secrete even more IgEs. And these stay stuck to mast cells and basophils for weeks at a time, right? So you're always pretty much primed during allergy season. That's why for me, every morning, Flonase before I left, Allegra with breakfast, right? So, and I'm still stuffy, right? I'm still battling. So when this reaction happens in the skin, it's commonly referred to as hives, and it'll look something like you see here. What's called the wheal, the puffiness, right, that inflammation in the skin, and the flare, the redness associated with that inflammation. And what you see here actually in this picture is somebody going through skin testing to see what they're allergic to, where they're actually poking and scratching into the skin, different known allergens that most people are allergic to. They can do blood tests nowadays too, where they can test and see what IgEs you have. and I had that done several years ago. When I originally had this testing done, my arm swelled up so bad that I had to take steroids after my testing because my arm got so swollen from the allergens that they poked into my skin. At the time, I didn't have any food allergies, and I don't even know what they consider what's wrong with me as far as me and wheat or gluten, but I had horrible headaches. I found out this summer that when I eat gluten, it's just terrible, terrible. So I had been poisoning myself apparently for years and didn't even know it. Until this summer, my dentist said, Erica, you need to stop eating grains. It took me about 2 months, and then I stopped, and then I slowly added them back in and found out that wheat was my nemesis. So, but things like thistle and ragweed really blew up. Like, if I'd known I'd been was going to be a teacher back then, I was in research then, I probably would have took a picture of my arm so I could show it to you guys because it was terrifying. I could not wear my watch for weeks after because it was on this arm. So all the pet allergens I did on my right arm, I stared at that arm, said if you puff up, I'm going to cut you off, because then I thought I was going to be a veterinarian. I'm still an avid animal owner and lover, so I would have been very upset if I had to get rid of my animals. Not allergic to them, right? Just all the pollen in the air and and gluten and me just don't mix anymore. Not best friends. But so for some people, right, so when you come in contact with things, right, and this has happened to me too, where I've gotten, nasty bumps and stuff like this on my arms and stuff when I come in contact with stuff. That's a local reaction. We can deal with that, right? Hives, right, so is that local skin reaction. And it can be itchy for some people, right, or it can be really painful even, in my case. Hay fever is the other thing that I suffer from, of course, and this is when we inhale stuff. So usually affects the nose, but also for some people, your eyes are constantly in contact with stuff in the air as well. So for some people, it gets very irritating for their eyes. Thankfully for me, not so much. Although I would not trade with my asthmatic friends, right, because that has to be the most terrifying. Where you have this reaction happening in the bronchioles. It's a little bit different reaction, so antihistamines don't work for them. It's different mediators that are released in that area, so they take different type drugs. The problem is the bronchioles, right, their airways constrict because they're trying to keep stuff out, right, because obviously you're inhaling something that's bad. So for some reason they're like, oh, let's try and keep it out. The problem is you need oxygen to live, right? Small problem, right? So no, not being able to get as much oxygen in as normal and getting rid of that carbon dioxide. That defense mechanism, if it continues for too long, can be, of course, life-threatening, especially if it goes pretty extreme. So these, although, asthma, as I said, can be quite severe, it isn't nearly as bad as generalized anaphylaxis, right? Where if something gets into your bloodstream and goes system-wide. Now, some people will get hives because of something that they ate, right? So in this case, what happens, it went into the bloodstream and it traveled to your skin, right? And then you had a reaction in your skin to that allergen that's in your bloodstream. The most common place in that case with hives, where it's going to show up first, is, of course, your abdomen, because that's the first skin that gets the blood supply from the food that you ate, right? And then it'll tend to spread up the chest. So it is possible, even though your skin didn't come in contact with something, right? You can ingest something, and those allergens could go to your skin, and you could still have a skin reaction. Still somewhat localized, right, because it's just in the skin. But there are other food allergies, right, where you can have the allergic reaction happening in the blood vessels themselves. And that's when it can be really scary and life-threatening. So although it's rare, but not so much anymore, right, because we inherit allergies. So peanut allergies are becoming more and more common because people aren't dying from them anymore. So they're growing up and they're procreating and having babies that are allergic to peanut butter. or peanuts in general. I don't know why, right? That poor nut gets a bad rap. So the problem here, right, is the fact that it goes into the bloodstream, right, and that you're having this problem over a large part of the system, and the drop in blood pressure that can be associated with this inflammation in several areas of the body. And I think we talked about this last time, huh? A little bit, right? And talked about EpiPens last time, right? Okay, good. We can skip over that. So immunotherapies, and I don't remember if I erased the next slide. I didn't. We don't have to worry about the one after this. This slide we're not going to go over. This one we are. So one of the therapies that's commonly used, it's called desensitization or hyposensitization. And I've been through this. I didn't complete it because I moved to California during my treatment and wasn't able to keep up with it. But what they did was they made a special cocktail just for me of all the things I was allergic to. And I would go every week, I want to say, and they would inject it into my arm. So they're purposely giving me, right, what I'm allergic to in small doses. Right? And then they would slowly increase the dosage. Why would you do that? Why would you purposely expose yourself to something you're allergic to? Normally I'm what? Inhaling it, right? So then it's going into those tissues in my nose, and unfortunately those B cells there are making what? IgE. What if I stick it somewhere else in my body? Let's say, hey, they're developing where you can take a pill now. So what if I ingest it? Is my body going to make the same type of antibodies no matter the route of entry? No, right? Because remember, stuff that comes in contact with our mucous membranes, we want to make what class of antibodies? IgA. So the thought behind this is introducing it, right, into the muscle, gets the body to produce a different class of antibody, gets it to produce IgGs. So that now when you inhale it, hopefully the IgGs are attaching to it and eliminating it before it's getting to your IgEs. And again, if we can stop this stimulation over and over of the IgEs, hopefully we will stop this cycle. And I can say that for the 6 months that I did it, Thistle was the one that made me not be able to wear my watch for a couple of weeks after the test. I don't think I'm allergic to thistle anymore. It didn't show up on my blood test. I'm still, unfortunately, quite allergic to ragweed and some other grasses. But it really helped me out with thistle, big time. And I was suffering so bad a few years ago, I was like, I'll go through the testing again if I have to be able to go and do the shots again because I was miserable. But a lot of it was contributed to inflammation from eating gluten. So since I've stopped eating wheat, a lot of the inflammation problems that I had have decreased significantly, which is really good. So, but apparently there's a pill. The FDA was in the final phases about a year ago, so hopefully maybe they've finished, although my allergist hasn't called me, that you could take for the grasses. So you wouldn't have to go in and get the shots. You could just take a pill, right, and hopefully get your body to start producing different antibodies instead of the... And then there are some people that do it naturally, expose themselves to the pollens in the area orally. Anyone know what they take each day? Teaspoon of honey. Unfiltered, right, non-pasteurized local honey, which you can buy at Holly Grove Market. You can take a teaspoon of that each day, and that'll help with pollen allergies. Help desensitize you to the ones in the area. That's why you want local honey, right? Because you want the pollen in the honey from the area you live in. Make sense? Kind of cool, huh? Right? So, it sucks immunologically for some of us, right? But the more and more we learn about the immune system, we can kind of get it to do what we want it to do, as opposed to what it's doing. So this is a more high-tech, and I have to say I haven't done any research into if it's even being used anymore or its effectiveness, so we're going to skip over it. So the next one is type 2, which is cytotoxic. So again, in its name, it kind of tells you what it's all about. So cyto refers to cells, and of course toxic is bad cells. So this is when there are cells in your body or cells that you're exposed to that are bad. And this one really only came about when we started doing blood transfusions and we started figuring out what was happening for some moms and their babies with hemolytic disease of the newborn. So both of these involve antibodies attacking red blood cells, but it's different antibodies depending on what antigens on the red blood cells we're talking about. And it's a particular antigen that causes the problem with hemolytic disease of the newborn. Anyone know what antigen that is? It's the Rh antigen, right? And so when somebody says their blood type, they say plus or minus, they're talking about that specific antigen, whether they have it or not. So like I'm O positive. So the only antigen I have on my red blood cells is the Rh antigen. And that's why we're concerned with that one, because that's the one that creates problems for us when we don't match our babies. But since I have the antigen, would I make antibodies against it? Am I going to make antibodies against myself? I have the antigen, right? Am I going to make antibodies against myself? No, not unless I'm experiencing autoimmune disease, right? So I don't have to worry about hemolytic disease in a newborn just to the fact that I have the antigen. So I'm never going to make the antibodies that are going to cross the placenta and hurt my baby. Now, there's only one class of antibody that does that, though, right? What class crosses the placenta? IgG, right? So it is just IgG that creates this problem. But unfortunately, it is also the antibody that we make against this antigen if we're exposed and if we don't have the antigen. So which types of moms have to worry about hemolytic disease of the newborn? Rh negative, which means they don't have the antigen, right? So if they're exposed to the antigen, what are they going to make? Antibodies. So when they're pregnant, these antibodies cross the placenta and attack the baby's red blood cells. Make sense? How do you get exposed to blood? Well, blood transfusion, right? Somebody screws up and gives you the wrong type blood. Can happen. Happens, right? Okay, so that's one way, right? And that's it for guys, right? Because they don't give birth. Lucky you, right? Women, on the other hand, you got that whole baby inside, right, that has its own blood because it's the combination of you and daddy, right? So if you don't have that antigen, though, dads could have had that antigen and could have passed it on to the baby, right? So you could be a negative mom with a positive baby. And this is where the potential is for you to be exposed to positive blood. Now, normally you have that barrier where the blood is not exchanged, right? The blood cells themselves, right? The nutrients pass from the blood in the placenta from baby and mom. There isn't a blood-to-blood connection, right? It doesn't mix. It's close contact, though, right? And so if there's any damage to that placenta during pregnancy, there could be mixing that happens. So that's one way that you could get, the mom could get exposed to the baby's positive blood. If the baby has positive blood. It's damage to the placenta during pregnancy. And this would be like, getting in a car accident or something like that. It's not very common, but it happens. The other thing is that when the mom gives birth, baby comes out, then you give birth again, it's called the placenta. It comes out, right? When it detaches, there is the possibility there of the exchange of the blood. So for negative moms, they will treat them with antibodies to attack the baby's positive red blood cells. It's called Rogan. So they're going to give that so that you don't make antibodies against the baby's positive red blood cells when you're exposed. That first baby doesn't have anything to worry about if you haven't made antibodies, right? But that first baby poses a risk to an Rh negative mom because it could expose that mom to positive blood. If you want to know about the horrors of that, ask Dr. LeBlanc. His wife is Rh negative and they've had 3 kids. Her last pregnancy, she had to go for lots of treatment because she had already started making antibodies. So to help not attack the baby, she had to go for treatments throughout her pregnancy. But if you're positive, right, no worries. Right? You're not going to make antibodies against yourself. Does that make sense to you guys? So that one's pretty easy. So what's the O mean, though? So I'm O. Anyone else know their blood type? What are you? You're O negative, so you've got to worry. And you had to get the room. It's not fun. Well, especially if you don't like shots, right? Yep. Yeah. So how many children do you have? Just one. But you had been exposed to positive, or you had to have it when you gave birth? Right. They didn't want to take any chances. Yep. Yep. So thanks, Dad, right? Anyone else know what theirs is? A positive. So what does the A mean? Means in the ABO blood group, and no one said B yet, you have the A antigen on the surface of your red blood cells, right? There are 2 antigens in the ABO blood group. There's A and B. O means we do not have either A or B, right? O, 0, none. In that blood group. Are these the only blood antigens out there? No. These are the ones, the most common that create problems, though, right? So there's like 20 different ones. They'll cross-match, right, whenever you need to get a blood transfusion. And make sure that what they're going to give you isn't going to cause a reaction. And they give you what's called packed cells. They're giving you just red blood cells, right? They're not giving you someone else's antibodies in their plasma phase. They've filtered that out, right? So you don't have to worry about that. But you have to worry about, right, getting an antigen you don't have. Right? So for her, only O negative blood can be given to her. You can't give her any A's, you can't give her any B's, and you certainly don't want to give her Rh. Right? Especially if she wants to have any more kiddos. You can't get an antigen that you don't have, because what are you going to make against it? Antibodies. So with Rh, you really have to be exposed to it to produce the antibodies. The bad news with the ABO blood group, the A and the B antigens, there are pathogens out there that we're commonly, or microbes that we're commonly exposed to throughout our lives that have antigens on them very similar to our A and B antigens on our red blood cells. So you naturally are exposed and produced antibodies against the A antigen and the B antigen if you don't have it like her and I. You're type A, so guess what antibody you have? Anti-B, right? You don't have anti-A because you are A, right? You have that antigen. Now, what if you have the AB blood type? What if you have both, right? Do you have any antibodies against A or B? No, right? We can give you any blood and it's good. Doesn't matter what antigen's on it, she's got them all. Right? Are you AB positive? Yeah, so she's got it all. We can give her anything, right? She's a universal recipient, where she's the universal donor, right? Everybody wants O negative because it has no antigens on it, right? So we can safely give it to anybody because it doesn't matter what antibodies you have. There's nothing to attack, right? It's basically a naked red blood cell, right? So it's like gold, right? Even O positive, right? The blood center is always sending me stuff in the mail. Once you donate blood once, forget about it. Every little t-shirt thing or giveaway, they're sending it to you in the mail. I haven't got one in a while, though. Maybe they've given up on me. I really low blood pressure, so the one time I donated blood, I almost passed out. So unless somebody drives me home, I don't have a driver right now. My husband's disabled, so I haven't donated blood. So unfortunately, because mine's pretty high demand. Not as high as O negative, but O positive's pretty precious too. Does that make sense to you guys? So back to antibodies though. This is the good news with this one, right? Is that which class of antibody do you think we make against the A or B antigens? It stays in the blood. Which one is big and stays in the blood? IgM. And this is why moms don't have to worry about that cross-reactivity between mom and baby as far as the AB blood type goes. Because those antibodies don't cross the placenta. Right? They stay in the blood. The bad news is right, if you need a blood transfusion, right, you get into an accident or you have surgery or something like that, right, and you're really low on blood and they need to give you a transfusion, they got to make sure they don't give you antigens you don't have, right? They can only give me O positive or O negative. So those of you guys taking in, how many are in anatomy and physiology 2 or have to take it? So remember the Nobel Prize website that I sent you guys to immunology? They have the best blood typing game on there. It's super awesome, right? So I always highly recommend that one. And they've improved the little animations that go along with it. It used to really upset me because the antibodies didn't look like antibodies, but now they do, right? So I didn't complain to them, but they fixed it anyways. I was so happy when I saw that. So it's really cool. Like patients come into the emergency room, like there's a car accident, and patients come into the emergency room, and you have to type their blood, and then you have to give them blood. You have to figure out which blood you can give them. It's a really cool game. I like it. So, I don't want to give you the answers just yet. Let's think about this for a minute, because the test is Tuesday, right? So, we make antibodies, right? And we know that process, right? B cells get activated, they turn into plasma cells, they make the different classes of antibodies, right? And for that class switch to happen, who has to talk to the B cell to get him to switch to IgG instead of making IgM? The helper T cell, right? Which is CD. Helper T cell is CD4, right? And how does a B cell present to a helper T cell? It presents that antigen in MHC class 2. Yes. So that's happened, right? And we produced antibodies, right? So we've already got those antibodies in. Some idiot in the ER gives you the wrong blood type, right? What happens? Antibodies bind to those red blood cells and agglutinate them, right? Clump them up. Well, you certainly don't want that happening. You want them flowing through the blood vessels. So that's problem number 1. But does it just stop there? No, what can antibodies do to red blood cells that have antibodies bound to them? It can lyse them. And how is it going to lyse them, though? So IgM can clump them up, right? But IgM can also activate a system in our blood that can destroy these red blood cells, right? What is that system? The complement system, right? And what is actually going to happen? How are the cells going to be lysed? What happens? Yeah, remember what are those little donut-shaped protein complexes that complement can form called? MAC, which stands for membrane attack complexes. So remember, one of the outcomes of complement is the MAC complex, right? A whole bunch of those proteins coming together and forming that donut-shaped structure and inserting into membranes, right? So complement activation by IgM. Remember, IgM can do that. What other class of antibody can activate complement? What's our other major class of antibody? Close. IgG. IgM and IgG both activate complement. So with hemolytic disease of the newborn, right, IgG, which is what we produce against the Rh, can activate complement and lyse the baby's red blood cells that way. So that's pretty much what happens, right, is that complement gets activated by these antibodies and it lyses the red blood cells. But there's one other outcome that can happen to the poor baby because of the class of antibody. Because IgG is coating a cell, another cell is going to come along and destroy that red blood cell. What is that cell that's going to come along and destroy it because it's coated in IgGs? It's a lymphocyte, but not an antigen-specific lymphocyte. What's NK stand for? The natural killer cells. Do you guys remember what that antibody outcome is referred to as? It's abbreviated ADCC. But what does that stand for? No, antibody. Antibody dependent, right? We're talking about antibodies here, right? Antibody-dependent cellular cytotoxicity. Right? So complement-fixing antibodies react with the surface antigens and cause cell injury or death. Right? If you have IgG, which is the problem with hemolytic disease of the newborn, you also have the additional problem of antibody-dependent cellular cytotoxicity. So antibodies are involved in this reaction, right? Antibodies were involved in type 1, but IgEs. Here for type 2, it's IgM or IgG. In the case of the newborn, it's IgG. In the case of ABO blood group, it's IgM. Either way, this is not good, right? Destroying red blood cells, the reason why we gave them to you was because you needed them. But unfortunately, your body recognizes things that are not self. So if it's not the same as you, it's going to attack. And in this case, with the aid of antibodies. So, as I said, there's that Nobel Prize website. That one's super awesome for the blood typing that you got to learn for A&P. But probably the easiest thing to remember, right, is don't give somebody antigens they don't already have. And you guys understand the principle, right, that you're going to make antibodies against stuff that you don't recognize, right? If you have that antigen, you're not going to make an antibody against it, because then you'd be attacking yourself. So distribution-wise, by race, you can see that AB is very rare, right? To have both of those antigens, one from mom and one from dad. O is quite prevalent among whites and Asians and even blacks. Where you see the difference here is a lot more Caucasians have A blood type than B, right? Where it seems to be pretty even among Asians and African Americans between having the A's and the B's. There's this other goofy website that one of my students had sent me to. In Asia, they're like real, and in some cultures too, they're real big about blood typing and like how you should eat based on your blood type. I don't know how much truth is to that. But even who you should marry, right, based on your blood type. It affects your personality, apparently. I don't know, I just find it slightly hysterical. I don't put any real scientific stock in it. So there's poor negative mommy, right? And again, she's the only one who has to worry because she's the only one that if she's exposed to positive blood is going to make these antibodies. And remember, it's just IgG. And the problem with IgG is this ability to cross the placenta and attack the baby's red blood cells. So heads into the baby, attacks the baby's red blood cells, activates the baby's own immune system against itself. So you may ask the question, right? Well, why is it that IgG can cross the placenta? Shouldn't it not then be able to do this? Wouldn't that be great? Right. Why do you think, what's the benefit of IgGs crossing the placenta? Right, it'll help with the baby's immunity. So if the mom, say, even gets an infection, that could spread to the baby. You want the mom's protection against it, too, to also be able to spread to the baby, right? To be able to protect that baby. So the only problem is here is that baby and mom don't match genetically. And in this case, it's against self. The next one is also involving antibodies, because what's an immune complex? An immune complex is antigen and antibody bound together. Normally, these are going to be cleared from the system, right? Phagocytic cells are going to maybe gobble it up, right? And destroy these complexes. But sometimes we get too much of a complex, and it doesn't get cleared, and it actually tends to deposit in several areas in the body. So we're going to skip over the animation. But immune complexes consist of, as I said, antigen and antibody. Certain instances, the complexes will persist in circulation and at sites of formation. So they'll deposit in the skin, and you'll get reactions, you'll get inflammation, you'll get like hives in the skin. They can deposit in the joints, right? And actually there's a disease where the immune system is attacking the joints. That's referred to as rheumatoid arthritis, right? Where your immune system is actually attacking the joints itself. But you can also have pain and inflammation in the joints when these large amounts of antigen antibody complexes, immune complexes, deposit there. The other bad news is that they are filtered through the blood and collect in the kidneys. Those really small blood vessels in the kidneys that are designed to filter your blood, to take the bad stuff out of your blood, to eliminate it out of your body in the form of urine. Connor, close the door for me. The problem is that, if they activate complement there, if neutrophils get called there, and you get damage to those blood vessels because of these immune complexes being there, you only have a set number of those functional units in your kidneys. They don't regenerate. So if they get destroyed, they're not replaced. So that's a scary thing with stuff like this, and especially if it happens a large amount of the system in your small capillaries. If you're getting destruction of those capillaries because the immune system are attacking these complexes that are present there, this can cause a really serious problem. So when this happens is really when, oops, I don't have a slide for that. Shame on me. When you have too much antigen, right, in the system. Serum sickness is an interesting phenomenon that happens, and again, it's when you have too much antigen in antibody complexes and they're not being cleared. So my favorite story as it relates to serum sickness is crazy herpetologists that love venomous snakes. So I actually took herpetology at Southeastern when I was doing my master's degree. That's because I was studying frogs, not because I like snakes. I'm terrified of snakes. My professor was like, "What are you doing in this class?" We had to go out in the field, right, and look for reptiles and herps. And of course, I was looking for the frogs. All the guys were looking for the snakes, right? And my professor almost stepped on a copperhead snake. when we were out there. And there was a whole mass of them coming together to breed. And yeah, I was terrified. I was going to lose my mind, terrified. And he's like, what are you doing in this class? I said, I want to know if I need to run or sprint when I see a snake, right? And I've pretty much figured out in Louisiana it's always sprint, because there's the enormous number of venomous snakes in this area, right? And I love the outdoors and hiking and camping. It makes me very sad that I'm terrified of these things. But if you get bit, right, they're venomous, right? This goes into your body, and there's different types of venoms. There's ones that will coagulate your blood. There are ones that are neurotoxins, right? So this is always why they kind of want to know what you got bit by. But if they don't know, they're basically going to give you all the anti-venom. And guess what anti-venom is? Antibodies against the venom, right? And back in the day, they used to give you horse antibodies. Horses apparently, I guess because they're so much bigger or immunologically they're more exposed, they'll produce antibodies, right? They'll get bit by a snake, a venomous snake, and they won't die. But of course, they would purposely inject them with venom to get them to produce antibodies to make the anti-serum for people. The problem with that, though, is the difference between us and horses, and their antibodies look slightly different from ours. So the first time you got that, you'd be fine. But the next time they give you that anti-serum from a horse, you could have a serum reaction where you have antibodies now against the horse antibodies. So you're going to start attacking the treatment instead of it helping you. So nowadays we don't do that anymore. Anyone know what animal is more closely related to us? Pigs. You're given pig anti-serum now. And we don't have those types of reactions. So you can be crazy herpetology guy and get bit more than once by a venomous snake, and we can give you the anti-venom more than once. And you won't have this serum reaction. Or you can get the really expensive stuff, where I really think that this guy has purposely injected himself with venom from snakes. There's a crazy snake guy out there who's immune to just about, I think, to all the venomous snakes. And I think, like I said, I think he's actually purposely injected himself with small amounts of venom to get his body to produce antibodies against it. And he sells his serum. And so would you ever have to worry about serum sickness if you get it from him? No, it's human, right? Your body isn't going to recognize it as anything but human, right? And it'll work every time. No worries with cross-reactivity. Make sense? All right. I'm going for water today. I don't even know if I'm going to drink this. Really unhappy stomach. All right. So that brings us to the last one, which is type 4. And this one is delayed hypersensitivity. And this is the only one we're not going to talk about antibodies. Instead, we're going to talk about cells, which is why a lot of times, too, it's referred to as delayed cell-mediated. Because unlike all the others we talked about antibodies, right? This one, it's cells. And because of that, the reaction tends to be delayed. It takes time to take effect. So anyone ever had the tuberculin test done? TB test, right? So what are they doing? They're poking you with a needle, but what are they giving you? Anyone know? They're giving you proteins to a relative to TB, right? Another mycobacteria, Mycobacteria bovis, right? They're giving you proteins from that mycobacterium, injecting it into your skin. So if your skin has seen that protein before, what's going to happen? It's going to attack it, right? But in this case, it's going to be a cellular response, right? They're injecting this into your cells. Macrophages gobble it up also, and they're going to present it. And cytotoxic T cells are going to come into the area too sometimes. But macrophages are going to gobble it up, And so this is going to be a cellular response. So this takes time. But this is they're only going to respond, right? They're only going to infiltrate into the area is if your body recognizes it, if it's seen it before. So what does that mean, though? If it's heading to that area, right, it's seen it before, right? So you're going to get a wound. What does that wound mean? You've been previously exposed, right? You've maybe had TB, right? Or maybe you have it right now because it's a very slow progressing disease that you can be tuberculin positive before you're even hacking up a lung. And that's why we use this test, because we can early detect cases of tuberculosis. The problem is that once positive, you will always be positive. So if you've had TB in the past and been treated and you're fine, you're always going to have a positive tuberculin test. It also stops us from being able to do what? Which would produce memory cells. Anyone been vaccinated against tuberculosis? No. Right? You usually don't hear about, or you haven't. No, none of us have been vaccinated against tuberculosis, right? Very few people in the United States population are vaccinated. Only people at high risk, people who work in tuberculosis and choose to get vaccinated. The vaccine isn't very effective. That's part of the problem. And we can't use this early detection if we vaccinate you. Because if we vaccinate you, your TB is going to be positive from then on. So we can't early detect with a skin test. Instead, we got to do what? We got to take a chest x-ray. Got to take a chest x-ray. So my ex-husband has been vaccinated twice against tuberculosis. Unfortunately, tuberculosis is very common in prison system. He wasn't incarcerated. He was a guard, right? He was a guard. So he was a guard, and he was also in the military and was deployed overseas. So he's been vaccinated against smallpox and anthrax and tuberculosis, you name it, he's been vaccinated. His vaccination sheet is like 5 pages long. He came back from being overseas and went to grad school at LSU. And there, because they have so many international students and so many more students than we have here, they require the TB test. So he had to go to health services, hand in all his vaccinations and get the TB test done. And he said to the little girl working at the desk, he said, she's like, well, you have to have the TB test. He said, why? It's going to be positive. She starts freaking out, right? And I'm like, who trained this girl, right? He's like, I just handed you 5 pages of vaccinations. It's on there twice. It is shitty vaccine, but, it's on there twice. Chances are he's going to be positive, right? So she's like, well, you have to do it anyway. She's like, okay, fine, whatever. So the little girl sticks him with the needle. A couple days later, it's still not positive. He's like, honey, I don't understand what the heck's going on. I said, me either. You've been vaccinated twice. Granted, it's got like 60 to 80% effectiveness for the vaccine. But I mean, twice, and you're no reaction? And he's like, he was cool because if he got a reaction, what was next? Chest x-ray, right? He wasn't looking forward to that. And I was like, you need to go report her. I think she screwed up. Because guess what? It's a protein, right? It'll settle out of solution in the vial. If you don't shake the vial and pick up any of the protein, he just got a saline shot probably. So not only is she freaking out because she's not informed, she's not even performing the test properly probably. Not good.
It's like a certain size for the spot too. My friend, he's like high risk because he has HIV.
Mm-hmm.
So he works at a bar though. And then he had a positive test, and so the doctor's getting a blood work done.
Mm-hmm.
And so I called my mom, and I was like, look at my friend's, he's like already at risk, and she's like, calm down. She's like, does it mean he has it? They're going to do a skin test, and she said it's over a certain size. Mm-hmm. She said the American drug, whatever, they have a certain limit they change it sometimes. But it says if it's under a certain size, they don't treat you. But if it's over, I don't know what she said. I kind of lost track of it.
But again, it's an early indication. But the thing is that, and this is why I talk about it extensively with you guys, is how many of you guys are going into the health profession, right? Most of you, right? This is our allied health class. So yes, the answer is going to be yes for most of you. And so depending on what line of work you go into, there is the potential that they're going to do this TB test once a year, and I've even heard about it being done twice a year. So they keep sticking you with this protein, right? They keep putting it in your body, keep putting it on your body. What's the chances that your body's going to remember it? The more often you do it, the chance is that basically this is almost going to be like being vaccinated, right? So there are people that sometimes will come up positive. So do me a favor, y'all. You're a nurse 10 years down the line. You should be pretty well educated by then, right? But don't freak out when you get a positive TB test immediately, right? Because it doesn't necessarily mean you have the infection. It means your immune system is recognizing that protein. That's what it means in essence, right? The next step is, why is it recognizing it? Is it because you've been exposed to the protein so many times, getting the TB test? You know, have you been exposed, right? If you've been exposed, obviously, to a patient with tuberculosis, then, you know, there's obviously concern. But what's also the good news when it comes to this? It's a bacterial infection, right? We do have antibiotics. The problem is that people don't stick with the regimen. It's a very slow-growing bacteria. It's intracellular. Remember, it causes those granuloma formations. So you really got to stay on your therapy and take it the whole time and really eliminate the bacteria. So therapy can be 6 to 9 months. And that's the problem, right, is that a lot of times people just don't keep up with it. And so we do have resistant strains, and that's where it gets scary, right? But that's why, too, international students, a lot of other countries, they vaccinated. So, you know, I'm sure she's had plenty of international students come in and come up positive, right? Because they've been vaccinated. Their immune system knows it already, right? They can't use this as early detection for them. Does it make sense to you guys? Right. If you understand the premise of how this test works, right, it's very important to know why and how. So if once you come up positive, you're always going to be positive. So you'll get a special little card, right, so they know. And then if you continue to work in the health industry, every year you got to go for your chest x-ray to check you out, make sure you're okay. Make sense? Okay. No one from my class is going to be freaking out in the future, right? All right, so for all of these, you need to know serum sickness. So what type of hypersensitivity do we talk about that one with? Type 3, right? The immune complex mediated. TB test, we just talked about it. It's type 4. And we're just saying 4 in numbers, right, because it's easy and fast right now. But notice I will give you the complete names, right, which really helps you out because it tells you a lot about what's going on. Hives. Type 1, asthma. Type 1, transfusion reactions. Type 2, hemolytic disease of the newborn. Type 2. And remember, again, these are all normal immunological responses, right? Making antibodies for all types 1, 2, and 3. You know, for cells to respond to foreign substances. This is all normal human reactions, right? It's just that sometimes they're not necessary. Right? Especially when it relates to pollen, right? Or the fact that we kind of need those red blood cells, but the problem is they're not matching yours, right? Not matching your system, so the body attacks. Immune complexes as normally, right? We want an immune response. It's just if we've got too much of it and it's not getting cleared, and we don't want it happening where it's not supposed to. So the one thing we didn't talk about with delayed cell-mediated, this also happens for some of the contact allergies that people have. So latex is not used very often anymore in gloves because so many people have developed allergy to it. We've gotten rid of them at Delgado. Some people can have an immediate reaction to latex or this delayed reaction. Or you can even have both, right? You could develop both. But this is also why, like poison ivy and poison oak, the good thing with that is that when it comes in contact with your skin, it actually takes quite some time to have an immune response, right? Because the cells are actually going to head to the area. There are special washes that you can buy if you think you've been exposed, and you can wash it off, enough of it off that hopefully you don't get a serious reaction to it. Unlike me, I didn't know one time playing paintball and laid down in poison oak. Yeah. That and those suckers hurt. I'm never playing that again. I had bruises all over my body from paintball. I don't like that game. The department's like, yeah, we need to go play paintball. So I'm sitting out for that one. I'll be cheerleader. Go get him! That and the last time I came away with poison oak, so I'm all good. Several months of steroids after that one, too. Yay! Nickel is a very common metal that's used in what's referred to as costume jewelry. So, like, if you go to Claire's and stuff like that, and you buy earrings and stuff like that, it's usually nickel and plated in silver or gold, and when that wears off, then the person gets exposed to it. So I have an aunt that's got a nickel allergy. She thought that was cool because then her husband had to buy her expensive jewelry instead of the cheap stuff. But because she's allergic. The chromium salts that they use for preserving leather, so a lot of people are exposed to, and they'll have a reaction. And, you know, T cells are going to release cytokines, and macrophages are going to come into the area, and you're going to get inflammation of that area. And it could be quite severe, as you see in that picture. Again, if I only knew, I would have took horrific pictures for you guys. So, as we're talking about these, right, what cell type is responsible? Well, if we're talking about antibodies, who's the bad guy? Mr. Who? B cells, right? B cells are the problem. So what type of antigen? I'm not so as concerned about with that, but, you know, they go over it in your book. Definitely the type of antibody matters, right? And the nice thing about type 1, right, it says it in its name, it's IgE, right? With type 2, we're dealing with IgM, and if it's hemolytic disease of the newborn, IgG. Immune complex mediated, it's usually the antibodies that are found in your blood. Which are the ones found in your blood? IgG and IgM. What other cells are involved? What mediators? How long does the reaction take? And do you get a reaction in your skin? So, of course, you know me, I like tables. So I made a table. Right? A little bit different from the one in your book because it goes into a little bit more detail than I want you guys to know. So the type of antigen, it can be what's referred to as soluble, which would dissolve in solution. And I don't know. I don't agree with some of these. So, like I said, I don't consider that one as important. But, you know, cell-bound, obviously with cytotoxic, because we're attacking our own red blood cells, those antibodies are on the cell surface. For immune complex, they tend to be soluble. And for delayed cell-mediated, it could be soluble or cell-bound. What's really important is the type of antibodies, right? And so we already just went over that one. And, of course, for the last one, any antibodies? No. No antibodies. Cell type, if we're talking about antibodies, we're talking about who? B cells, B cells, B cells. For this one, we're talking about T cells. Remember, T cells are the ones that communicate with cells. Other cells involved, right? For IgE, it's those darn mast cells and basophils that the IgE attaches to. For cytotoxic, it would be natural killer cells, remember, with the IgG and antibody-dependent cellular cytotoxicity. For immune complex mediated, it's other white blood cells like the neutrophils and macrophages responding to these immune complexes not being cleared effectively. And then again, other white blood cells like macrophages, and maybe even cytotoxic T cells as it relates to delayed cell mediated. Mediators, so what's a substance that we don't like that gets released from basophils and mast cells? Histamine. What complexes with IgM and IgG in the blood, it can cause reactions? Complement, right? For immune complex mediated, how do white blood cells communicate with each other? Cytokines. And also you can get activation of complement here. So this last one is white blood cells talking to each other, so this is cytokines. But this one can also be cytokines, but the major problem too is complement activation. So how quickly, we say IgE mediated, so how quickly could the reaction happen for that immediate, literally seconds, right? Seconds to about half an hour, right? Doesn't take long at all. Because again, IgE is already attached to the basophil. So once the antigen attaches, poof, release a histamine. Cytotoxic, right? Hours to days, right? So when you get a blood transfusion, it won't be right away. It may take a little while. It may even take a few days, depending on the extent. Immune complex mediated as well, hours to days. We're delayed, we're going to be talking about not minutes or seconds or hours. We're going to be talking about what? Days, right? So 48, right? 2 to 3 days. 48 hours to 72 hours. I think it's standardly 3 days they look at the tuberculin test. So can you get a skin reaction with IgE mediated? Yeah, what do we call that skin reaction? Hives. Right? The wheal and flare, right, reaction, which is commonly referred to as hives. With a blood transfusion, you're going to get a skin reaction? No. With immune complex mediated, could you get a skin reaction? Yes, if the skin is involved, right? So if the immune complexes are in the skin, then you can get a reaction. It's referred to as arthros. Delayed cell mediated, do you get a skin reaction? Yeah, especially if they're doing the tuberculin test, right? They're injecting it into your skin, so you're going to get a reaction in your skin. And sometimes too, right, that contact that people have with latex or nickel or poison ivy and poison oak, it happens on the skin. So definitely, right, that's a very important chart. Here's the one from your book. Real quick. And then the last of the stuff, there's not a lot of questions, right? And it's pretty straightforward. I don't want you guys memorizing any of the autoimmune diseases or anything like that. Just read about it, right? And understand that autoimmune means attacking self, right? And most of us are aware of things like HIV and stuff like that. But know that other things can cause your immune system to be deficient. You can be born with defects like SCID, is severe combined immunodeficiency. Both their B cells and T cells don't develop properly. So they have basically no adaptive immune. So this is the bubble boy, right? So that's what the bubble boy had, was SCIDs. Severe combined immunodeficiency. No adaptive immune response. So, you're stuck with just innate, which sometimes, as you know, isn't enough to take care of the problem. Hence why, limiting your exposure to pathogens by living in a bubble. Most kids who have that genetic defect aren't actually even born. They die in utero, right, if they have that severe of an immune defect. But there are other ones that, you can live with, and they're not going to kill you, but they definitely put you at disadvantage, and you have to be careful. Like not being able to produce enough antibodies to protect yourself. And thankfully, people who donate blood help people like that out, because your antibodies in your blood are then given as therapy for people who can't make enough antibodies on their own. So what are the antigens we worry about with transplants? What do your cells use to communicate? What do your B cells and T cells and macrophages use to communicate? MHC. Major histocompatibility complexes. That's where they got the name. Because when they try to do transplants, right, our cells didn't recognize those foreign cells. They couldn't communicate with them. That's what they're trying to match up as close as they can, so the immune system doesn't automatically go, I can't communicate with you. You don't know the special handshake. You must go. Right? So those are the major problems. So what immune cells are going to be involved then? Well, definitely which cells usually check out MHC. T cells. Which ones? Helper or cytotoxic? So you have a liver, right? And so you've got a whole bunch of liver cells. What MHC are they going to be expressing? MHC class 1. What T cell does that talk to? CD8, which is cytotoxic. So he can't talk to him, right? He's like, oh, I can't talk to you. You must be bad. I'm going to kill you. Right? So cytotoxic T cells and even natural killer cells can get involved. So what do people who have transplants have to do? They have to take immunosuppressant drugs for how long? Forever. Unless you plan on getting rid of that organ, which you probably won't because you will die, right? That's the reason they gave it to you, so you would live.
But they had in the news that this HIV patient, and she died. And they take her liver and transplant it to another HIV patient.
Oh, another person that already had HIV? So you don't have to worry about transmitting the disease? Yeah, that's the worry of a disease. And so that's the problem too, is that, you know, if they give you someone else's organ, it could potentially be disease. But they test for all known diseases. Known diseases, right? We can't test for things we don't know about yet. And there was a time that we didn't know about some diseases where people got diseases from transplants. But again, when you're getting a transplant, you're going to die or you're going to live. So maybe getting a disease in the process, I don't know, you know, dead, disease, right? You see? Yeah. Yeah. And Jehovah Witnesses, I think, don't believe in blood and again, there's a scientific reason to back that up, right? You could get a disease, right? But you also could die.